Hello, Dr. Morten Høgh.
Hi.
We are here with a very important man, I will say, because it is true, in pain science. And we will ask him a few questions. But before that, I want to present you a little bit. So, Dr. Morten Høgh is associate professor in the University of Medicine from Aalborg. He has a very long clinical expertise, and he has a master's in pain science and a PhD in neuroscience. Okay, so I will ask you a few questions, and we'll see what kind of information can we give to the community from Romania.
Can I say thank you for giving me this opportunity?
Sure, it's our honor to have you,
My pleasure.
but of course. Since in Romania we don't really study pain that much in the Fizioterapia University, can you tell us about the importance of pain science?
Yes. I mean, it's a long story, I would say, but essentially breaking it down, our patients are in pain.
Mm-hmm.
For many patients, there's not a disease or any single reason why they're in pain. So for many people, we see the pain is complex. For many years, we've tried to understand it through biology or pathology. And it turns out that most pain is not understood that way. So in order to understand our patients, we need to understand pain.
Of course, and that is a problem that I find very some kind of comic, but not really, because we are treating pain every day, and we know sometimes so little about pain.
Yeah.
What is the biggest myth about pain that physios still believe, if you think that there is one?
I mean, the biggest myth about pain is clearly that we think, physios think, that it's about loading or unloading. Mm-hmm. So we have this innate belief that it's biomechanical.
Mm-hmm. We have these methods that we all learn, and they all teach us about loading and unloading. And sometimes it's not really just, I mean, always it's not really just about that. Okay, if you could change one belief about pain in physiotherapy, what would it be?
I would love people to understand that when patients benefit from treatment, it is unlikely to be for the same reason as they were taught or that the theories apply. So when you do treatment and a patient gets better, there's probably a lot of things going on. We call them non-specific effects, but it relies on how you work with the person in front of you. So one thing that we could change would be going from a sense of being an expert in everything to sharing this expertise with the patient and understanding that they are the experts on pain and we are the experts of opportunities.
Yes, and this is a very complex problem, and it's about ego, about we and how we understand ourselves. It's a big change in our belief. So why can two people with a similar diagnostic, like let's say herniation L5S1, have different experiences? One can have pain and the other does not have pain sometimes.
Yeah, it's only interesting because we assume they would have.
Mm-hmm.
I guess the real question is, why would you think they do? Because we describe one dimension of what it means to be a human being. But it's like anything else. Someone eats a big sandwich and someone eats a small sandwich, and they might be equally satisfied afterwards. Or someone sleeps 7 hours, someone sleeps 9 hours, but they might be equally well slept. Mm-hmm. So we tend to believe that, again, coming back to this biomedical belief, that the body is like a machinery, like a car. And if there's a flat back tire, all cars respond the same. And that's not true for people. We as people with the conscious experience of the world are way different. So it's no surprise once you understand people and understand consciousness, or try to understand consciousness and sciences, it's really the norm is that nobody responds alike.
Okay.
Fortunately, I'll say for us, if there is like a broken bone or rupture or something, we do respond alike. So that's what we, sometimes see, is that most people respond the same way after surgery. Nobody has no pain, and some has really extreme pain, but the majority of people would be similar. So there are certain things where we respond similar. But in many conditions, with pain, for instance, there can be a ton of different variations of why people hurt. So why would they react the same?
So could we say that sometimes our body can adapt to a lot of things that happen to it?
I think the body adapts all the time, but we don't know how that relates to pain. So in the case of inflammation, for instance, your body does not adapt in a way that makes you feel less pain. If anything, you would have more pain. So adaptation or changes are innate, they're normal for the body.
So what you're telling me, it's some kind, a lot, let's say, close to what we say sometimes to our patients. So this leads me to the next question that is about communication. So is communication or soft skills, let's say, a really important thing to work on as a physio, or is communication key in physiotherapy?
I think that's a loaded question. Let's try and paraphrase it, because I think communication has always been key. We are maybe more aware now that it also causes effect. So even when you were fixing bodies, when you thought, that your methods were the only thing you needed, and you just follow a program and then you'll find the error, etc. So you still needed communication, but you used it for a different purpose. You used it to get your information, the important thing that you think are relevant, right? Whereas now we would use the same techniques, so open questions and active listening, etc. But you would try to make the patient tell more about their life. And obviously communication is maybe have a bigger play in the game. And you could, to a large extent, use also communication, so patient education, for instance, as a treatment.
So as you taught us in these 2 days, which were very interesting in this acute and chronic management, evidence-based management of pain, we can move from a clinician or an expert-centered to a patient-centered care.
Yeah.
If a Romanian physiotherapist watches this interview, let's hope they would, and wants to start improving tomorrow, what should they do first?
I think they should reach out to you and ask what you did. There's a lot of places to go. I mean, the lack of consistency is probably the big problem. So you go somewhere and they say one thing, and another place they say another thing. And if you start out in a game, it feels like it's overwhelming or that nobody agrees. But once you get a bit deeper into it, or you do courses like this one in 3 modules, you'll see that actually much of the information is the same, and it's not overwhelming, but you probably need it in bites.
I see. So we'll take it, let's say, step by step.
Yeah.
Right? Tell us how and where to find information about what you teach or pain in general, because, this is a really important thing to know where to search for the information.
Yeah. So in terms of where to go for information, it's hard to find good evidence-based information. I've been part of developing something called the EPIC Academy. So the European Pain Federation has an academy. There's a small cost to use it, from subscription. But there's a lot of videos that you can use on all things for doctors and psychologists and nurses and obviously physios. So there's a good place to go and get some resources. Otherwise, there's a ton of good podcasts out there. There's lots of relevant people. I guess the trick is to be critical, to not believe everything you hear, but to ask yourself the question. So this person says that. What would that mean for me? And do I agree?
I see. So you and your courses, do you post them on the pages that you have?
I used to be a lot of social media, so I have an Instagram account and I do have a Facebook account. I tend to use them quite a lot less now, but I'll try and post courses there. Otherwise, I think the only place I'm sort of consistently coming back to would be LinkedIn. Okay, I see. Otherwise than that, I can confirm that the EPIC Academy is a good way to go and search for information. Awesome. Thank you for the interview. It was an honor to ask you a few questions. Thank you for having me.